let's start our clinical discussion today with a case scenario. So you are working in the labor ward and you have been called in for an emergency. You've been informed by your staff that there was an induction of labor for a patient in view of past dates. This was done 2 hours ago, and her reassessment is supposed to be 4 hours later. But the staff who's called you for help has informed that the patient is already contracting and she notices certain abnormalities. So you go to assess the patient. And when you reach there, you realize that the patient is in an intense amount of pain. The uterus is contracting at the rate of 5 to 6 times in 10 minutes, 50 to 60 seconds almost. And in this process, you also realize that there is some amount of fetal distress. You do a pelvic exam to urgently remove whatever induction method was utilized, and you notice that she's already dilated and she started leaking and there is meconium. So what does this entire scenario point towards? You're right. It is a case of hyperstimulation, and that brings us to our discussion on abnormalities of power with respect to abnormal labor. So what is an abnormality of power? They can be hyper or hypotonic dysfunctions. But before you realize what that is, you need to first know what is the normal mechanism of uterine action. So uterine action is nothing but uterine contractility, and we will discuss certain key points about it. The first thing is the fundal dominance. You all know that there are two pacemakers that are located near the tubal ostia, and that is from where the contraction will originate. The second thing is the direction of movement. The contractions will go from the upper segment to the lower segment. Okay, you understood that? The next thing is the intensity. It's always going to be more on the upper segment, slightly less on the lower segment. So it gives you a gradient of activity. The next point is going to be that because of this uterine activity, there will be retraction of fibers that goes from the lower segment into the upper segment, resulting in a progressively thicker upper segment and a thinner lower segment. So what is that going to do to the cervix? It's going to cause two things. It's going to cause effacement. All right. So effacement means thinning of the cervix, and it's going to cause dilatation. Dilatation means the cervix is going to open up. So effacement and dilation. So after this, in addition to the effect of the uterine action on the cervix, you've got changes on the baby. So what changes happen here? So you're already aware that for certain essential key steps are there in the mechanism of normal labor. These involve changes in the fetal head. So the first thing is engagement, right? After engagement, you've got descent into the pelvis. After descent, you've got internal rotation. After internal rotation, once it hits the pelvic floor, the fetus is then going to be born, and you're going to have crowning followed by external restitution or external rotation and birth of the fetus. All of these movements also rely on the fact that you are having a good amount of uterine action, because it is the give of the pelvis plus the force from above that is going to help the fetus descend. So the same thing is pointed out here. A good uterine activity is going to give you the necessary changes in the fetal head and the cervix. So what would you define as a good uterine activity? For that, you have certain parameters. You're going to look at the frequency, the duration, the intensity, the relaxation, and probably the baseline tone. Now, another thing you need to realize is when the uterus is contracting, right? So if this is your uterus, this is the placenta, there is some amount of blood here, and blood is coming to the uterus from the maternal side to the placental side. Now, when there is a contraction, this blood supply gets momentarily interrupted, which is a natural phenomenon because the uterine vessels get clamped. Now, this will not affect the fetus because there is still some amount of blood here. Now, imagine the contractions become so frequent and so regular without a relaxation time between that the blood supply is not getting time to get refilled. And that is going to cause reduced oxygenation, and it is going to result in fetal distress. So this is another factor to realize, that with regards to contraction, even the relaxation is just as important, because any variation in any of these parameters will result in an abnormal uterine action. So, like I've mentioned, for uterine activity, we have certain definitions. So when you communicate to someone, the person is having adequate contractions, you need to discuss all of these parameters. First being frequency. So frequency is supposed to be anything less than 5 contractions, but ideally you would say 3 to 4 contractions in 10 minutes. Okay, each contraction would last for how long? 35 to 45 seconds. Obviously, between the contractions, you would have time of relaxation. So you're having 3 to 4 contractions for 45 seconds in 10 minutes. That means you're having approximately 15 to 25, 30 seconds between contractions for relaxation. This is enough for the uterus to refill with blood to help with fetal oxygenation. After that, you have these two factors. Now, in these two factors, you've got something called baseline tone. Now, baseline tone, even though it is actually a technical definition, it is not used in the technical sense in clinical practice, because this was done using intrauterine pressure catheters, which I'm pretty sure none of you would have seen because it's only used in clinical trials. So what do we do with baseline tone? Baseline tone you get from clinical experience. When you keep palpating a pregnant woman's uterus, you will realize that when she is not in labor, it is soft, relaxed. Versus when she's in labor, between contractions, there is some amount of a tone to the uterus. It doesn't feel as relaxed as always. Usually people say that this can be anywhere between 10 to 12 millimeters of mercury. But again, it's more of a clinical feel. Where can you tell me one condition where the uterus is always tonically contracted without relaxation, and this is associated with bleeding and fetal distress, if not IUD? You're right. So that's called abruption. So that is where baseline tone matters, because in abruption, you're going to have a persistently elevated baseline tone. The next thing is the intensity. Intensity is also a clinical field. So what do? When a woman is having a uterine contraction, you will palpate the fundus. So when you're palpating the fundus at the peak of uterine activity, you are unable to indent the fundus. It is woody hard. Versus when the contraction has ceased, fundus feels soft. You are able to palpate and indent it. So all of this together will give you an idea as to how the uterine activity is for the given scenario. So just remember these basic cutoffs, because you will use this as your benchmark whenever you are assessing a woman in labor for two reasons. One, to tell you whether she is in normal labor or not, whether she is progressing well or not, whether you feel you should give her oxytocin to augment labor. Because if you're giving oxytocin, you are trying to reach this benchmark of 3 to 5 contractions, 35 to 45 seconds. You don't want to go beyond this, because that will fall into hyperstimulation and your intervention is going to cause fetal distress or morbidity for the mother. So let's go into the topic as such. Let's classify abnormal uterine activity. So we already had this discussion in the beginning itself. It's got two spectrums, one where the activity is increased and one where the activity is decreased. So hypertonic and hypotonic. Hypertonic is further classified into subdivisions where you have got your tachysystole or hyperstimulation, which is because of iatrogenic intervention, and in 20% it can be a natural phenomenon. Incoordinate uterine action, from the word incoordinate you understand that the fundal dominance is lost. These both together can result in a phenomenon known as precipitate labor, which means labor to birth interval of less than 2 hours. This is hypertonic. On the other spectrum, you have hypotonic, where the uterine activity is less. So let's first start with the easier and less pathological version. You have hypotonic uterine dysfunction. So with regards to everything that we mentioned, the frequency, duration, intensity, what are the changes with hypotonic? They are infrequent. That means less than 3. They are of short duration, that usually 20 to 25 seconds, if not lesser. Low intensity, that means they don't reach the 30-35 mm of mercury. They're very, very low. So when the woman is having a contraction, you're easily still able to indent the uterine fundus. All of this is ineffective, right? Because they are not strong enough like the normal uterine contractions. And that is going to cause failure of cervical dilatation, failure of descent, and what is that going to present to you clinically? It's going to present as a slow progress or an abnormal progress of labor. So, one other point to realize to differentiate this from an incoordinate uterine action is the gradient remains normal. That means there is still a fundal dominance, but everything is just low. The contractions, the duration, the intensity, frequency is all low. So another point to realize is a woman will not complain of as much pain as a normal laboring person would have from your clinical experience. One important point I am going to repeat n number of times throughout this class is going to be on CPD. Rule out cephalopelvic disproportion. Now why I say this is, when you have CPD, so this is the uterus, here you have your fetus, alright? So their pelvis is not adequate. There is some disproportion for the baby's head versus the maternal pelvic diameters. Now, because of this, the uterine activity is unable to overcome this obstruction. So what does the uterus do? The uterus is going to reduce its uterine activity because it feels it is unable to overcome this obstruction, and there is no point of the uterus continuously contracting. So that is why when you have a hypotonic uterine dysfunction, you are going to think of trying to increase the uterine activity by medicating the patient. But before you medicate, you must rule this out, because if you medicate and she actually has CPD, you are going to cause an obstructed labor, or you're going to cause increase in the manifestations of CPD that is going to result in an even more difficult birth, whether it is an assisted birth or even a cesarean. So here is the comparison of what I said: reduced frequency, reduced duration, reduced intensity, and the fundal dominance remains the same. So what are the most common causes? So you have to understand the mechanism in which uterine action occurs. So if you have given the patient analgesia, so there can be some amount of muscular relaxation that will result in hypotonic dysfunction. Now this is an exception, and you have ruled out CPD. So this is an exception where you will give oxytocin, because you know that there is a reason for the hypotonic dysfunction. Now let's go on to the other two causes. Chorioamnitis. What happens in chorioamnitis is there is going to be infection within the uterine cavity. This endomyometritis is going to cause dysfunction in the myometrium. So obviously an inflamed myometrium will not act as a normal uterus would. So that is why chorioamnitis is going to cause uterine dysfunction. Overdistension. Overdistension, just look at this. If you had to compare these two uteruses, like a singleton versus a twin, wouldn't you expect a larger uterus having a harder time to contract effectively versus a smaller normal sized uterus? So overdistension because of polyhydramnios, multifetal pregnancy, fibroids, etc. will also result in a hypotonic uterine activity. Nulligravida is another cause, because generally nulligravidas are prone for some amount of labor dysfunction, and sometimes that will be because of CPD. So you need to rule out all of these things and take into assessment. So if a woman has come to you with PPROM and now she's in labor and you're suspecting dysfunction, what could be the cause? Right, chorioamnitis. And preterm labor itself is not a very normal labor. It's already an abnormal labor. If a twin comes and they're not progressing well, you are suspecting overdistension as the cause. If a primey short 138 centimeters comes, you're suspecting CPD. So these are how you will rule out these possible mechanisms. So now let's go into the management. So most of the times hypotonic uterine dysfunction is because of dehydration or exhaustion. So if you have realized that now the new partogram takes into account maternal hydration status and emotional well-being. So by ensuring that she's well dehydrated and supported during labor, that she's got both emotional and physical support, that itself will be able to take care of most of your causes of hypotonic dysfunction. Now this does not work. she's ambulated, she's well hydrated, she's had something light to eat as well, yet still the uterine activity is subpar. So what do you do next? You look for CPD, you look for malposition. What do I mean by malposition? I mean anything that is not occipito-anterior. It could be occipito-posterior, occipito-transverse, or it could be a malpresentation which you did not realize, such as brow or face, or maybe even breech. So you have to look for these two factors. Both of those factors are not there. Everything is normal. Everything is normal. Then, in addition to your general measures, you will then reassess the woman in 4 hours. Because 4 hours, you're expecting that she should have a minimum of 2 centimeter dilatation if she is a primary. That means at the rate of 0.5 centimeter per hour, or 1 centimeter if she is a multi, which is approximately 4 centimeters in 4 hours. So 2 centimeters in 4 hours, 4 centimeters in 4 hours for primary multi. An average definition is just take it as 1 centimeter for everybody, so you'll remember it better. Now, you notice that there is no progress. You have tried the general measures, nothing has worked. Now you have two options. Now you need to remember these two options are common for most of the labor dysfunctions, and I will keep explaining that again and again. What can you do now? So the woman is hypotonic activity, right? You have ruled out CPD. You have tried general measures. They have not worked. So now you have two options. You will either do an amniotomy, that is you will do an ARM, or you will give her oxytocin. So which one would you choose? If she's more than 6 centimeters dilatation, ARM would be preferred, because you already know that when you're doing an ARM, you are going to strip the fetal membranes from the lower uterine segment. How does that work? So if this is the uterus, this is your bag of membranes. As you are rupturing this, you will stimulate this area, and that is going to release prostaglandins into the circulation, and it's going to increase uterine activity. And this is something known as the Ferguson's reflex. Okay, this is actually mainly with respect to induction of labor or stripping of the cervix, but the same concept even works when you do a ARM. So that covers hypotonic uterine dysfunction. Let's go to the more sinister hypertonic. Now in this you've got tachysystole, incoordinate uterine action, and these can result in precipitate labor. So let's first talk about tachysystole. Tachysystole means woman is having more than 5 contractions in 10 minutes. This is not going to give the uterus enough time to fill the intervillar space. So because of that, the fetus will not get freshly oxygenated blood regularly, and that is going to result in fetal distress. So most of the causes of tachysystole are due to intervention. It could be oxytocin or misuse of prostaglandins. Now prostaglandin misuse means that you have given it to the wrong patient or inserted it wrongly. So for instance, a person who has a Bishop score of probably greater than 8 for that matter. That means someone who's almost got a 75% effaced cervix, 3 centimeter dilated. Now such a person would have responded to oxytocin. You did not need prostaglandins, but we have instilled it because we're worried the patient should not go for failed induction. Our good intention has resulted in a tachysystole. So that is why proper patient selection before any form of pharmacological intervention in labor is important. However, having said all of this, 20% will occur in spontaneous labor. That just basically means 1 in 5 women who present in spontaneous labor are likely to have tachysystole, which is going to result in fetal distress. So again, like we did for hypotonic, let's compare all of these variables. Okay, so you know frequency is increased, right? Duration is increased, intensity is high, basal tone is high. So all of this is going to result in frequent, strong uterine contractions. But remember this, gradient is normal. Where else was gradient normal? You're right. It was also normal in hypotonic dysfunction. Why am I insisting on remembering this if it's always normal? Because in the next scenario, it won't be. So how do you manage a tachysystole? So first, take care of the intervention. If there was any misoprostol use or oxytocin being used, stop or remove them, right? We will then do general measures. General measures means left lateral positioning, giving an intravenous bolus to flush the system of the prostaglandins. You may consider oxygenation. Some recent recommendations from society say that maternal oxygenation for fetal distress is not going to help, but there's no harm if you use it judiciously. All of this has been done, but the contractions are still present. Okay, so what can you do next? Tocolysis. So for tocolysis, you can give them an injection of terbutaline. Now, despite this, the contractions are not ceasing, and obviously the fetal distress is now persisting. If the fetal distress persists, you are worried that persistent fetal distress is going to cause fetal hypoxia. Hypoxia is dangerous because that is going to result in a neurological disability such as hypoxic ischemic encephalopathy. This has a very important impact on short and long-term neurodevelopment. So before we reach this stage, we want to stop it. What can you do for that? A cesarean. Very rarely, sometimes, the woman might be fully dilated, the head might be below the level of the spines, and you have an experienced consultant who is well versed in doing mid-cavity deliveries. So if that is available, you may consider doing an operative vaginal delivery in the theatre, which is called a trial. So you can consider a trial of operative vaginal delivery or CS depending on the clinical circumstance. But the answer is you will stop the labor immediately. So let's talk about the second kind of hypertonic dysfunction. This is incoordinate. Incoordinate is also going to have hypertonic dysfunction where frequency is increased, basal tone is increased, intensity is increased. But this is the differentiating factor. Gradient is not maintained. So what happens because of the lack of gradient and the improper contractions? Remember, I told you two things were important for a good uterine action. A good uterine action is going to cause changes in the cervix and help with fetal descent, flexion, internal rotation, right? Now, you have an incoordinate uterine action. This is not going to happen, this is not going to happen, and you're going to have an abnormal progress of labor. That is not the only thing. The woman is going to experience extremely painful contraction, which is going to distress her and is going to cause emotional distress. So, most important thing with regards to incoordinate uterine action is sedation. So, this is a similar mechanism of how we manage false labor. We were not very sure whether the woman is actually in true or false labor because the uterine contractions are not giving us progressive cervical dilatation despite the woman's complaint. So there also we give sedation. Here also we give sedation. So why are we doing this? So the mechanism of incoordinate uterine action is, in addition to the fundal pacemakers, they have got random pacemakers throughout. All of these are shooting incoordinately. So when you give the woman sedation, you are going to take care of all of these pacemakers. You are just going to have your fundal pacemakers alone. So that will convert an incoordinate uterine action to a normal uterine action. So while you're doing this, you will also give her hydration because dehydration can also aggravate an already existing pathology, right? Now, what can you do next? You have done the sedation, you have given the IV fluids and still nothing has worked. So what is the next step? Like I said, always rule out CPD, right? You feel contractions are ineffective and you are getting a delay. What are the two things that we can do? We can do an ARM or we can give oxytocin. These are the two things in our armada to always help a dysfunctional labor, but always rule out CPD. So now let's come to a combination of the other two hypertonic dysfunctions. They will result in something called precipitate labor. Precipitate labor is the duration from onset of labor to birth of less than 2 hours. Now this really doesn't sound that bad because lady has not experienced pain for that long and she births immediately. But that is not the case. Now, what happens with precipitate labor is, for the lady may not realize that she's in labor, so she may not be able to reach the institution in time. So she cannot have a planned birth in a proper facility. It usually happens in women who are not able to understand pain sensation, who are having a combination of these two, where they're having extremely strong uterine contractions and they're having a lack of resistance in their pelvis. So all of this is going to cause a rapid descent and dilatation. So what will that do? For the baby, it's going to cause dysfunction with oxygenation because the uterus is not relaxing. So fetal distress and rapid molding, rapid engagement and descent and rapid birth is going to cause fetal hypoxia. And that is why fetal distress, fetal hypoxia is important, resulting in a low APGAR. This can cause trauma. You can have fractures, neurological damage such as brachial plexus injury. Now, if you talk about the mother, you can have lacerations, cervical trauma, 3rd and 4th degree perineal tears, any form of traumatic PPH, even atonic PPH for that matter, abruption, because as the uterus contracts, right, sudden decrease in the uterine size will shear off the placenta, resulting in an abruption. And as you know, abruption is also going to cause fetal distress. So these are the complications of precipitate labor. So let's just briefly summarize everything that we've learned with abnormalities in uterine activity or abnormalities in power. Okay, so you've got hypertonic or you've got hypotonic. Hypotonic is relatively easy to remember. You must rule out CPD, right? You've ruled out CPD. If everything is fine, then you can consider augmentation with oxytocin, or you can give an ARM if she is eligible for it. Now, when it comes to hypertonic, you are thinking of tachysystole. So, tachysystole means you take care of the prostaglandins or the oxytocin that you have used. You give IV hydration. All right. If all of this doesn't work, you give tocolysis. If that also unfortunately doesn't work, you will terminate the pregnancy in the form of CS or an operative delivery, whichever is feasible. Now, if it's an incoordinate uterine activity, right, here you're going to give sedation, because you're assuming when you give sedation, you're going to take care of all the other pacemakers. Now, after this also you feel the activity is not that good and you've also hydrated the woman. Despite all of these things, the next step is going to be again oxytocin or ARM. But remember, before you do any intervention, rule out CPD, the most important thing. So, the basics of our do no harm. Don't give a pharmacological intervention if you're not sure of your diagnosis. So, this is as easy as it can be. Whenever you see a patient, if she is actually in labor, confirm whether she's in active or whether it is false labor. And if she's in labor, look at her contraction frequency and see if it is giving a progressive cervical dilatation. So the contraction should have proper frequency, intensity, duration, proper tone, and a good amount of relaxation. If any of these criteria are not met, look into what could be the cause, classify it, and try to intervene appropriately.